We know life with HCM can feel complicated, and sometimes it's hard to know where to begin. The good news is we do. It starts with an intake call with our staff, where we listen and learn about your concerns. From there, we help connect you with our navigation team, who can answer questions about your condition and help you prepare for conversations with your HCM specialist. Intake and navigation help you make the most of every appointment. Learn more about our intake and navigation services at 4hcm.org.
Good morning, everybody. It's a Thursday podcast, and that must mean it's Dr. Patient Alex Feria from the University of Pennsylvania, and we are here today to talk all things HCM. I'm Lisa Salberg. I will be your host today, and we have a couple of quick announcements before we get into the topic of the day, which is Arrhythmia Management March. We're going to talk about sudden cardiac arrest risk assessment. We're going to talk a little bit about atrial arrhythmias. And of course, we're going to be talking about late-breaking hot topics. So to start out with, April 23rd, the Hypertrophic Cardiomyopathy Association will be conducting a patient-focused drug development meeting with the FDA and a number of our advocacy partners, including the Dannons Foundation, the SADS Foundation, Dilated Cardiomyopathy Foundation, Friedreich's Ataxia, Feria, and the Amyloid Research Consortium. So we are all coming together as the community of the genetic heart muscle conditions to talk to the FDA about our wantings and our hopes for genetically based therapies and RNA-based therapies for our future treatment. These things are not reality yet. They're under development, and we need the FDA to understand what it means to live with the diseases that we live with, and also for us to have the opportunity to try potentially new therapeutics that may be beneficial, and if they're proven over time, to get them labeled and get them out to the public. We are a long way from that with gene therapies, and we are closer with mRNA-based therapies for amyloidosis, and there's some things heading towards HCM as antifibrotics and other interesting mechanisms. So if you want to listen live, it'll be 12 to 5 on the 23rd. You'll be able to phone in, you'll be able to participate in live survey questions. But before we get there, we want to make sure that we have a really good foundation to talk to the FDA about modern HCM and genetic heart muscle disease management. So we need everybody to take this survey. Let us know what you've been through, what you're going through, what you want to try to avoid going through in the future, and your burden of disease, so that we can articulately express to the FDA what our needs are as a community and where we need their help. So, Dr. Patient Alex, what do you think about that?
I think it's great. I mean, having the patient's opinions and interests as a part of it, I think is really important. On the other side of it, we're so focused on all these novel therapies and things like that, and talking about, like you said, antifibrotic therapies. But I find it quite valuable to hear what patients want. Like we talk about these, like the antifibrotic therapy, that I think that's an interesting one. They could have impacts over time, but the patients aren't going to notice that in the short term. And so that's like, I don't know, sometimes I think we have a hard time connecting the two. So surveys like that are quite helpful.
We've got 1,500 respondents so far. I'm hoping to get it well over 2,000. It will then be one of the most well-published and well-populated surveys that PFDDs have had. So we want to make sure that we're making that bang and making sure that they know what we're dealing with. It's not necessarily what you see on the surface. It's what happens when we go home and we're trying to live our normal lives. What's going on in the moments that you're not in the doctor's office. So let's get you all to do that survey, and we can hopefully get enough information to make a compelling case that we need to try new therapies and continue our clinical trial journeys to get people to full health if possible. So that's part one. Part two, I'm getting out of here in just a few minutes and jumping on an airplane, I hope, and heading to New Orleans for the American College of Cardiology conference this weekend, There's a number of interesting articles being discussed on, or not articles, but presentations and some abstracts and some posters on all things HCM. So stay tuned over the weekend through social media. I'll be dropping updates as we go. I might even be doing some on-the-fly podcasting. I got some new equipment. I might be talking to some people live from the floor. We'll see what happens. I don't know. Cross your fingers. Other things up and coming. I know it's a little early, but in October 9th, 10th, 11th, that weekend, we are having our annual patient meeting again here in Morristown, New Jersey. There's going to be a new way to help you as patients fund your way to get here. If you do a fundraiser through the program that we've set up for the meeting, you might be able to pay your entire weekend off by doing a fundraiser. We are looking to cover our costs, not make people go broke coming to a meeting about their heart condition. So we've come up with some new ways to help people get the travel money, or even have us pay for a ticket if you earn enough money. So there's ways for you to be here. And if you're interested, if you're East Coast, we have our relationship with Angel Flight that can actually help fly people in for the meeting. If you're further away, then we can help you with just commercial transport on that. So, and then the hotels and then the weekends events and the food and all of that stuff is covered. We're really starting to focus on the development of a couple of new programs. Number one is, what do we do with our patient registry? What questions do patients really want answered? And what data do we now have that we might be able to address some of those questions? And we're creating a new program called Hearts and Minds, a mental health network. And we're probably going to do some focus grouping and some feedback and listening sessions about the mental health journey of those living with HCM while at the meeting. So please come out and join us. It's a fun time to spend with your big-hearted friends. And we all learn a lot, and we laugh a little, and we might hang out at the bar sometimes too. So, we're just normal people with weird hearts. So that being said, it is March, which means last month was my 9-year heart transplant anniversary. I'm currently still wearing the old technology to check out Brandy, and I had a PET scan this morning with that lovely chemical that they throw in you and makes you think you're going to die for 30 seconds, or it was 3 minutes, but then we don't, and we're better. So even though I don't have HCM anymore, my heart journey continues. It continues, and we move forward. Alex, how are things in Pennsylvania? What's going on?
Things are good. The program is very busy. I think this week I will have seen 9 or 8 new HCM patients, in addition to all my old ones. We're expanding. For now, I will likely be going, and hopefully during the summer, start going to New Jersey, to Robbinsville, New Jersey, and eventually the Princeton site. So I know we have a lot of patients from New Jersey that are constantly asking when I can start going there. So hopefully soon we'll be there, and thinking about other potential sites to help expand access.
I love expanding access, and I'm going to talk about the thing that people have known is going on for a long time, but we're now able to make a public statement about it. So as many know, Morristown Medical Center is going to be changing. Matt Martinez will be moving south to Mayo Jacksonville, April 12th. And there is a transition plan in place that I've been working very closely with the hospital on. They will have 6 months from Matt's departure to be able to reestablish themselves as a fully functioning HCMA recognized center of excellence. And at the conclusion of that 6 month, either we are good to go with a new team, or we are going to sunset a program. We are hoping that we're going to be all systems go for a new team. That is our goal. That is what we're hoping to do. But in preparation for maybe that's not going to be a good solution for everybody, we know that our friends at UPenn are moving into Robbinsville, so New Jersey will have some additional coverage there. And I have had a site visit earlier this week at another New Jersey campus. I will refrain from saying which one, but the goal would be to have more than one program in New Jersey, potentially 3. And then the outreach from the UPenn, which would equal 4 different programs. So hang in there. I know change is hard, but we are working very closely with the team to make sure that it is as seamless and as safe as possible, because that is our goal. And for those of you who know, I live right here in the Morris County area, so Morristown is very near and dear to my heart. It's also where my sister passed away in 1995. So I have a real interest in making sure that it is a robust program and that it meets our qualifications as a COE as it reforms. So I know some of you are nervous and scared about this change. Hang in there. We have mechanisms, including telehealth, that will be able to keep you in touch with the physicians that you might want to stay in touch with. So we're working on systems, I promise. And this isn't something that just happened in the past couple of weeks. It has honestly been something we've been talking about for well over a year. Just because I don't talk about it publicly doesn't mean it's not happening. And here we are today. And we wish Matt well, and he'll be back with us next month podcasting. He'll just have a different office. So while the HCM community does not lose Matt Martinez, Morristown will be losing Matt Martinez. And it's okay, we still get to keep him. So that's my update. Alex, what else is going on at UPenn that's going to help us bridge the gap over care in Jersey?
Yeah, I mean, the physical expansion is something that I'm leading, and so that part will happen slowly but surely. We haven't totally ironed out the details yet, but I have a lot of patients that come up from Delaware. Hopefully at some point soon we'll have a footprint in Wilmington, which will help, because the other thing that we run into is just from an insurance standpoint, it can be is particularly New Jersey. Patients have such a hard time, even if they live right across the border, coming over to be seen and getting testing done here. And so hopefully with getting licensed and going to those two sites, that will decrease the burden. And the goal is not just seeing HCM patients, but establishing a myosin inhibitor program at those sites. So if patients need to be on mavacamten or aficamten, they can. And also eventually expanding our research trial network so that if people want to participate in trials, they can see a research coordinator and get echoes done at those sites. That's the long-term goal I have in mind, because honestly, that's been a huge impediment for some of our patients that want to participate in trials, in particular, like non-obstructive HCM, where there's not that much on the market yet. Like, to be able to do a trial is challenging because it's a lot of visits and coming into Philadelphia. And even if it's not that far to get to Philly, just like the 5 miles radius around the hospital can take you 30 minutes. That's what I hear from all my patients. I grew up going to a center in Atlanta and I hated it. And so just hated going into Atlanta. And so now I am that center. So it's
yeah, that gets a little complicated when you're moving around that much and you're not comfortable navigating the cities. It can be a bit daunting. So getting access to high quality imaging, clinicians who know what they're talking about, it is much more logistically challenging than I think some people give it credit for.
Yeah. I mean, we're going to have to take sonographers out to these sites and train up sonographers on how to do the studies, and it's going to be a big lift. But I think we're gonna get there.
Okay, Nina, we're going to get to your question in just a moment, and I think we're going to start it off with a question that'll frame your question. Okay, Alex, let's take a step back. We're going to get into arrhythmias in a minute, but you mentioned that you're getting like 8 or 9 new patients a week with HCM or with a thick heart. So can you just level set people as to when somebody walks in, that we're not living on the assumption that it's HCM, that we need to still prove it's HCM, and how do we go about proving the diagnosis? And why do I make a big deal out of this? Because not all thick hearts are HCM,
Yeah.
and not all thick hearts require the same therapies. So how do we figure out why your heart's thick?
Yeah. So, I have a tremendous respect for all the doctors that refer patients to come see us, because, it takes some humility for a cardiologist to send their patient to another cardiologist. And so with that being said, every single patient I see, my first question is this HCM or not? It's not a foregone conclusion. And because of that, it's not uncommon that we will diagnose other conditions that look just like HCM. In particular, one that comes up quite a bit is amyloidosis, where the heart can look thick, the heart can have obstruction, it can look just like HCM, but it's a very different disease. It's a very different treatment with a very different outcome. And so that's one thing that I'm looking for. And then there's other forms of HCM that aren't true HCM, but due to things building up in the heart, that there can be specific treatments for, like Fabry disease or other conditions like that, PRKAG2 disease. So there are different things that look just like HCM, and you really have to think not just on the initial imaging. Usually an echocardiogram is not enough to really nail down the diagnosis. Almost every patient I see will get some other testing unless if there's a reason they can't get it. But I usually start with an MRI. And more recently, I've started to lean on getting, especially for a condition amyloidosis, specific testing looking for amyloidosis. Because even this last week, patient was transferred into our hospital from Delaware on mavacamten. And I looked at the echo and I looked at the MRI and I was like, that looks a lot like amyloidosis. And so even the MRIs, sometimes I used to think, and I read MRI, I read echo, I used to think that MRI was like really, really good at differentiating amyloid versus HCM. And sometimes it's just not as clear. And so I have been getting more advanced testing, one nuclear scan called a PYP scan for patients that I'm suspicious have amyloidosis. And so, do not be surprised if when you go see your doctor, especially if you're older, you have some other symptoms that sound that they could be related to conditions like amyloidosis. Like a lot of patients will have kidney disease. They'll also have issues with their spine, there's carpal tunnel. There's a lot of things that you think about globally with a patient when you're trying to figure out, could this be something else? It's very important because, some of those conditions have very targeted treatments that are very different from HCM treatments. And some of those patients you do not want to put on some of the HCM treatments. And so I think whether the clinic is labeled as a thick heart clinic or not, the provider seeing the patient should be thinking that. Like, is it HCM? Let's make sure it's not something else first. And then we go down the decision tree of what to do.
Thank you. Nina, I'm going to jump into your question before we get into arrhythmias because it's on topic here. Nina's saying she has non-obstructed HCM and a pacer implanted. She asked her cardiologist about meds and said that only 0.02% of thickness. I don't know what that doctor's talking about. By the way you're explaining it to me, that doesn't mean that the doctor's incorrect. I just don't understand what you're saying here because those are not words that we use in HCM. So there could be some miscommunication. There could be something else. But your second comment made my spidey senses jump. And that was, you asked her about a specialist. She didn't like that. Well, my dear friend, I don't know who your cardiologist is, but the minute they get funny about you getting a second opinion, it's probably the time you need to get a new cardiologist. Because this is a team sport. If somebody's trying to capture you and keep you without getting expert insight onto a disease process that is not incredibly common, then I think you may have the wrong person. I would not be comfortable with that person. They may be a lovely human being and I'd love to have dinner with them, but I don't know that I'd want them as my treating cardiologist. So I would encourage you to go to the HCMA website, find a center of excellence near you, get a second opinion, and then choose who you want as your home cardiologist working in partnership with your specialty center. So Alex, I will just...
I always empower my patients that, including, that they've come to see me. And if at the end of the visit they're hesitant or they feel like, I'm not sure, like, how can this be right, what you're telling me? I say, you know what? You always should talk to multiple providers if you're not sure or don't feel comfortable with that. I myself have seen like 4 or 5 specialists, HCM specialists, as a patient in my life, mostly due to geographic reasons, not for lack of trust. But you should always feel empowered. In the end, it's your life.
It is your life, and I will add in one other item from your original comment. Non-obstructive hypertrophic cardiomyopathy is rarely treated with only a pacemaker. So I'd be asking the questions, why do I have a pacemaker? What is its purpose? You could have heart block. I have a transplanted heart with heart block, so I have a pacemaker, but that doesn't necessarily mean that's the go-to treatment. Why do you have a pacemaker? What is she talking about? 0.02% thickness. That's not how we measure things.
Yeah. And depending on your age,
Yeah.
the presentation for HCM is, I think I have 2 patients that presented with heart block. Like, it's not a common presentation. There are other conditions that can look like HCM, like cardiac sarcoidosis, that can present with heart block. And, so really searching to make sure you've arrived at the right diagnosis is, like we said earlier, thick heart, great, maybe it's HCM. What else could it be?
Awesome. Alex, thank you for that. And Nini, I hope we were able to provide you with some guidance. I would also encourage you to do an intake and navigation call with HCMA so we can ensure that you have all the resources that you need to make the best decisions you can for yourself. So it's March, and we're coming to the end already. It's hard to believe HCM Awareness Day was a month ago. Feels like yesterday, but here we are at the end of March, heading into ACC. So thinking of arrhythmia, and thinking of Arrhythmia Management March, the first thing that people think about when they hear about HCM is sudden death, dum, 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 and we get very concerned about that because it's awful, and we're trying to do everything we possibly can do to avoid that. Alex, how well do you think we are today at assessing sudden cardiac arrest risk features in those with HCM?
I think that we're a lot better than we used to be. And I think, even as a provider, there's always a little bit of internal struggle about, there's variability depending on where you are in the world and which provider you see about how they think about your risk. And so, some providers are a lot more conservative. Other providers are a lot more liberal about putting defibrillators in patients or offering them defibrillators. What I would say is I think we've gotten a lot better. I think, every time I see a new patient, I break down the way I think about the conversation in my mind into 3 buckets. One of them is, what are your symptoms and how does this impact your life? The other one is the inheritance and genetics aspect of this and making sure nobody else has it. And then the third big bucket is the risk assessment part and the sudden cardiac death part. And one thing that I think a lot of times can be surprising to patients is the disconnect between how you feel and the risk. Some people can feel great and have tremendous risk. And other people can feel terrible, and we go through all of the risk factors and they don't have any high risk criteria and don't meet criteria for an ICD or a defibrillator, which is an implantable device that can help save your life if you go into an abnormal heart rhythm. And I think that's honestly one of the biggest disconnects that we have to work through initially.
You're the ones that scare the hell out of me, I'll be honest.
Yeah.
I don't have any symptoms, but my walls are 3 millimeters and I've got a lot of scar and I have a family history that's not so good, but I feel fine.
Yeah. And so I think that breaking into those 3 buckets is important. I think saying it out loud as a provider is important because almost everyone has either Googled or ChatGPT'd or something HCM before they come into that room. And the first couple things that pop up is sudden cardiac death, even though it is not that common. Like the rates of sudden cardiac death, and you'll see different things, but annually, some say 0.5%, some say 1%, and that's across the board, right? Like some people have risk factors and their risk is way higher than that. But I would say that it's an individualized discussion. And even when we give you data and we can get scientific about, based off these risk factors, this is the likelihood that you will have something happen in the next 5 years. I also think you need to individualize that, right? Like if you have a patient in front of you and you say, oh, you have a 3% chance or a 4% or 5% chance of having a sudden cardiac death event. Some patients will say, great, that means I have a 95% chance nothing's going to happen. And then someone else will say 5% is way too much. I've got 2 kids at home. I can't take that risk. And so it's not just about looking at the data, but it's individualizing it to the person. That's where the shared decision-making kind of decision comes into play. Other people, it's much more clear-cut. Like someone in your family died suddenly, you have a lot of scar in your heart is very thick, you've passed out multiple times, I'm worried about you. And even then, sometimes as a patient, you're like, well, I don't think I'm ready for this. And then it takes a longitudinal relationship and talking with your doctor and talking about the risks and benefits of devices to make the right decision for you. But it's a nuanced complication or a nuanced issue with HCM that deserves like a third of that visit, that first visit, in my mind, deserves it just to talk about that.
I would agree. The individuals who are young and otherwise healthy, other than their HCM, who have these risk factors and say the things to me like, I'm waiting for this life event or that life event, or I want to do this before I do that. If I told you the number of times that they didn't get the chance to make that second decision because they were waiting. Somebody wanted to finish their finance degree. Somebody wanted to finish college. Somebody wanted to find a girlfriend. Somebody wanted to wait until their daughter was born because their wife was pregnant and they didn't want to put her through that person having surgery. Unfortunately, in that case, he never met his daughter. So we don't get a second chance sometimes. And I think people need to be acutely aware if they're told they have high risk features. Everything else is kind of wild card at that point. We don't know when or if it's going to rear its ugly head. So please listen to your specialist. But on the other side, I wouldn't be so quick to put in a device if a community cardiologist said, oh, you have HCM, go get a device. I've seen that happen a lot too. And on the other side, just, oh, well, we'll just put a device in because you have a disease that is scary to me. That's a bad idea too.
And I think that is the value of having a multidisciplinary team that can look at all of the data, right? Like it's not uncommon, and this may sometimes applies to some of the other genetic heart diseases that I see, but where you get a genetic test and it shows a gene, and if someone doesn't interpret that genetic test correctly, they might jump to conclusions of it, oh, you definitely have HCM, and you passed out and ICD. And there have been times where then our genetic counselors will go through that result and be like, this is actually not consistent with disease. So then that risk factor goes away. And then you go into the story and it was a seizure and not passing out. And so then that risk factor goes away. And so it is a nuanced conversation. And then also not even if the device is appropriate or not, getting past that, let's say you've decided a device is appropriate, making sure you know what all of your options for devices are and what kind of device you should get. Some people are probably better off with certain types of devices than others. And we can talk about that a little later, I'm sure.
I'm going to end up doing a full webinar on 2026 devices because so much has changed over the past couple of years. We used to have just first we had a shock box that went in your abdomen. Then we figured out how to put it up in the chest. And then we figured out dual chamber pacing and defibrillation. And the leads have changed, double coils, single coils. There's all these different technologies that are new. And then we jumped into the SICD, which had some benefits, but some problems. And now we have the EVICD, which gets rid of some of the SICD problems, but it's a little bit more complicated to get in the right place. So there's all of these new technologies for just cardiac rhythm management that we're going to have to break down, and we don't have enough time or detail to go into in a podcast because some of these are better seen visually, and we'll do that in a webinar.
Yeah.
So
that let me know if you want, because one of our electrophysiologists that I refer to a lot has put in many of the newer EVICDs for me, and our patients have done great. And so if you want someone that has experience, there's a different way to think about every HCM patient and what their EKG looks like and what their risk factors look like and which device they should get.
And I think it's really important now that there are more choices and there are differences in function to not only know which device is best for you, But as the EV-ICDs are newer, not every program is doing them at the same level. And some are like, I don't know, it's new, I don't want to do it yet. So you may have to travel to get that implanted. And then hopefully over time, they'll be able to manage them closer to home for you. It's just the new technology bubble that we're living in right now. So let's pivot for a second and let's talk about the most annoying arrhythmia in hypertrophic cardiomyopathy, which we all know is atrial fibrillation.
Annoying is a good word for AFib.
It's just, if you have a bad ventricle that doesn't want to do its job, and then the atrius decides to go on partial strike as well, we just feel horrible in atrial fibrillation. So let's talk a little bit about what AFib is, difference between AFib and A-flutter, because some people try to make them sound like very different things, but they all kind of feel the same.
Yeah.
So let's dive into the atria.
So we spend a lot of time talking about the bottom chambers, the ventricles, because hypertrophic cardiomyopathy primarily causes the left ventricle or the bottom left chamber of the heart to get really thick. But there's a lot of things that, as a consequence of HCM, can happen with the top chambers or the atria. So those are the chambers that receive blood. And then they pump that blood into the bottom chambers. They load those bottom chambers to pump blood to your body. Well, with HCM, because the heart is thick and the ventricles, when you're trying to move more blood through a smaller space, because the heart cavity gets smaller as the heart gets thicker, that drives the pressure up in the heart. And the pressures then are transmitted to the top chambers, those atria. And atria are not meant to live in high pressure worlds. They're very thin walled structures. And the more pressure you see in the top chambers, the bigger they will get over time. And when you stretch those top chambers out, the electrical system that's running through there also gets stretched. And that puts a lot of strain on the top chambers of the heart. And over time, it's unfortunately common in HCM that those electrical signals start going haywire. And the way I would think about AFib is, instead of having a nice signal coming from where it's supposed to come to tell the top chambers to squeeze, a bunch of different signals start shooting off in the atria. And when that happens, the top chambers, instead of having a nice coordinated contraction, they're responding to all of those different signals. So instead of squeezing, it's almost like they're a bag of worms. They just do this. And the term we use is fibrillate, and they just sit there and quiver. And when that happens, the top chambers are no longer squeezing. They're no longer participating in loading the bottom chambers with blood. So just that alone decreases your heart's ability to pump blood forward. And on top of that, because that blood is just kind of pulling there, it puts you at risk for clots and stroke. And so unfortunately, I would say the vast majority of patients with HCM that go into AFib feel like they just fell off a cliff. Like it's like almost like a light switch went off. And many of my patients can tell me the minute it happened and that they felt bad ever since then. But in a handful of the patients, they have no idea they go into AFib. And unfortunately, sometimes the way they present is with a stroke, because they had a clot, they were in AFib, they didn't know it, and then they have some sort of neurological symptom and present like that. But that's AFib, and then flutter is like a cousin of AFib. Instead of it being a bunch of random little signals, I would call flutter like a loop in the top chambers. It's also abnormal and also fast and also puts you at risk for clots. Most patients feel similarly in flutter and fib. And so they're both very annoying rhythms from the top chambers of the heart that make you feel pretty awful.
I think that's about as technical as we can get on that one. They're yucky. They're just yucky rhythms. We don't like them.
The conversation continues, but first, this quick break. For more than 5 years, the HCMA has brought people together through online discussion groups for newly diagnosed patients, caregivers, women with HCM, and young adults. You are never more than a few hours away from support, understanding, and shared experience. This February, HCMA launches a new men's group. Find the next discussion on the events page at our website. Once again, here's host Lisa Salberg.
So I was recently having a conversation with a bunch of surgeons. And my question to the surgeons was, if you're going in for a myectomy, how often are you clipping the left atrial appendage to remove clot risks? And they're like, we do it all the time, but insurance doesn't like to do that anymore. And they're getting pushback from insurance. Like, if you're already in the heart and you know this person has a risk of arrhythmia and thereby a risk of clot, why are insurance companies pushing back on clipping the left atrial appendage when it literally takes minutes during the surgery? So I'm a little confused about the hypothesis there.
Why would insurance companies not pay for cardiac rehab, for HCM, or like if you had
If you touch the mitral valve, they'll pay.
I know, but should we really? And we do end up having to do something to the mitral valve many times, right? But like, why do you have to even justify that? All I'm saying is insurance makes no sense half the time.
Because they're trying to practice medicine without a license, and that could be a podcast in and of itself. How many times has the insurance company gotten in the way of the doctor-patient relationship? I can name like 10 just from the past month of my life.
Yeah.
So I'm a little bitter about that. Right?
Yeah. What I will say is ligating the left atrial appendage, while it does help reduce the risk of stroke,
Doesn't bring it to zero.
not eliminate it. And so I have my patients, even if they got ligated, if I'm concerned and they were off their anticoagulation or whatever, we do it. We take a look at the appendage before we do anything, because you will see times where clots can still build up with that. So.
Just remembered my tag note for the end of the day. I forgot to say something to somebody. Okay, so AFib management in 2026. We tried all the drugs. They don't all work so great. What is our go-to at this point, and then when do we go more aggressive?
Yeah. So I have the benefit that I am in a center that has a lot of very, very good electrophysiologists. So those are the electrical doctors that can do procedures called ablations to try and get rid of the AFib. There are also good medicines that sometimes are enough. I find that many, especially with my younger patients, I am early leaning towards doing a procedure called an ablation, where they go in and they find where the abnormal rhythms are coming from and get rid of it early. What really breaks my heart is when someone's been in AFib and they were left in AFib and they stayed in AFib for a while and they felt terrible, and then I meet them a couple years later, and it's harder to get you out of AFib if you've been in AFib for a long time. And so my practice is I tend to be pretty aggressive at getting you out of it and keeping you out of it early. And again, you'll get different opinions on that, but my approach is to get rid of it early. And so we do a lot of ablation. One of the medicines that we use to try and keep people out of AFib is one called Ticasin or dofetilide. That one has worked pretty well in our HCM patients with not many symptoms and side effects. As long as your heart rhythm and kidneys can tolerate it, patients do really well with that. So sometimes we need to do an ablation to get rid of it and a medicine to keep you out of it. Sometimes ablation's enough alone. Sometimes patients opt to just do medicine alone. So there's a lot of different ways, but I think the most important thing is, if you detect it, to act on it early. Because if you sit in AFib for a long time, it gets much harder to get out of AFib.
AFib begets AFib. And you explained earlier, like, what's going on to the muscle. We don't think of the atria as being muscle, but the entire heart is muscle. And if that muscle gets stretched out, there's a reason I like brick walls behind me when I give podcasts. Cell structure is supposed to look like a nice, pretty brick wall with cells and collagen, and this is how it's supposed to work. If you're stretching that atria and those cells are not in their normal form, they're going to transmit electricity differently than they would if they were normal cells. So the more it stretches, like think about a balloon that's been stretched too many times, it doesn't always go back to its original shape. So we really need to think about the whole muscle in the collective, rather than thinking that the ventricle is a muscle and the atria is something different. It's all muscle.
Yeah.
And we got wonky muscle and wonky valves, but they work pretty well.
Yeah. And, I think there's probably something intrinsically abnormal about atria in patients with HCM, that it's not as simple as high pressures causing them to get bigger. Like, I have a couple patients with HCM that have normal-sized atria and go into AFib, and so I think it's more complicated than we realize. Especially with the genetic forms of HCM, those genes make up the whole heart. It's not just the left ventricle.
Yeah, I wish we could communicate with them a little bit more effectively to tell them to stop being so troublesome, but those cells are everywhere and that DNA is wrong. And as I often explain it to people newly diagnosed, the blueprints were wrong and the bricklayer had a few drinks that day. They're just putting it together a little bit differently. It works, it's still a wall, it still moves well most of the time, but we don't quite get there. But we are prone to arrhythmias, and therefore we are good consumers of implantable devices and technologies in which to force our heart back into a more normal rhythm. Back about, I would say more than 5 years ago, when we talked about ablations for atrial fibrillation, we would say your first one, you got a 60% chance of it working. And then the second one, you got another 20% chance. And the third one, another 20, which left some people still in AFib. But we've got new technology today. So even if you failed a prior attempt to ablate, you might still have options. Do you want to talk about pulse field ablations and what we're learning?
Yeah. I mean, there's different techniques for ablation. There's ways where you can put energy in the inside of the heart. Sometimes we borrow some of the technology. You've probably heard of an alcohol ablation that has been used for treating HCM. But sometimes when you have deep scar in a very thick ventricle, sometimes they'll actually inject alcohol into a small little vessel. It's actually a vein, not an artery like we do with ablations, like for HCM alone. And you can actually target abnormal heart rhythms that way. Sometimes there's scar on the outer surface of the heart, and it's very hard to get it if it's in the middle. And sometimes these electrophysiologists will ablate from both sides of the heart muscle. So they access what we call the epicardium, the outside and the inside. And so there's, at Penn, many of our patients are repeat ablation patients. It's not the first time they've been ablated. It's not that the person who did the first ablation necessarily didn't do a good job. It's just a complicated ablation.
We have complex anatomy, and the rule book was not made for us. We take pieces of the rule book, and then we try to make our hearts comply when we're not starting with the same anatomy.
Yeah.
We have a different anatomy.
Yeah. Yeah, and even with AFib, I think that make sure that you're fully informed when you're going to get a procedure done, that you understand what they mean. I had a 30-something-year-old patient of mine who has a genetic form of HCM, very large atria, went into AFib for the first time ever, and she's Spanish-speaking, and she ended up in a hospital, and what she was offered, unfortunately, was a procedure where they just ablate the communication from the top part of her heart to the bottom part of her heart. And so I could understand why they thought about that, but she was in her 40s, and I said, please no, and then transferred her over, and then our plan is to do an AFib ablation. We had to leave her in AFib for a little bit because she had clots in her heart, but we plan on doing an AFib ablation soon. And there's just a lot of thought process, not just about getting rid of the arrhythmia now, but like what impact is this going to have on this person for the next 30 years? And so just make sure you understand when the doctors are talking to you about what they're offering, that it all makes sense when they're doing it.
And it's okay to stop and say, I don't understand, or go get additional resources and support. Our discussion groups and some of our trained moderators have been through these processes before and can help peer guide you while you're working with a specialist so you know what to expect. So we have 2 comments coming in. Gwen, I always think of you when I talk about this topic. So hello, how are you? And Alex knows who Gwen is too. So she likes a discussion on AFib and atrial configuration, but what's going on with CMIs in the atria? So myosin inhibitors, and just for those who are newer to us, so we're talking about mavacamten, which is Camzyos, and now aficamten, which is Mycorrhiza. So what do we know about myosin inhibitors in the atria?
Yeah, so when they did all of the original trials for both mavacamten and aficamten, there was a part of it where they looked at folks' echocardiograms on these drugs, and they didn't just focus on what happens to the obstruction, but they also focused on what's happening to the pressures in the heart and the secondary effects on the other chambers. One of them being the left atrium, or the top chamber right above the left ventricle. When you have severe obstruction, the pressure in the left side of the heart is very high. And a lot of times there's also a lot of leakiness to your valve that causes blood to just shoot back into the top chamber every single beat. So that's a lot of stress on the top chamber of the heart. It's constantly making it fill with blood and dilate. And in both the mavacamten trials and the aficamten trials, we looked at something called the left atrial volume index, which is where we measure the volume on ultrasound and index it to your body size to see what is a normal left atrial size for you. And many of the patients had a dilated left atrium. I would say most have at least a mild, if not a moderate or severely dilated atrium going into the trials. And across the board, most patients, the size of their left atriums decrease when we take the pressure down. When we get rid of the obstruction, when we improve the flow through the heart, the size of the left atrium in many patients will get smaller, which is a good thing. We think of that as a good remodeling to try and get back to where they were before. And so far, the impacts on the structure of the heart have all been good that we have seen. And that is something that we have shown again in real world data that we participated with multiple other centers to show that the sizes of the left atrium are improving. There was small signals for AFib in the trials in patients on myosin inhibitors, particularly in the mavacamten trials. I think that's hard to interpret in the setting of a disease where people are going to get AFib just intrinsically. And in the mavacamten trials, or aficamten trials, they did something interesting and I thought clever, which is they used one of the HCM risk scores for developing AFib that Ethan Rowan came up with. And they looked, if we looked at all the patients in this trial and estimated how many people we thought would develop AFib just at baseline based off their starting characteristics, and then we look at how many people actually developed AFib in the trial. This was MAPLE, which was obstructive HCM. At least what they found was that the rates of developing AFib were actually no worse, if not slightly lower, than they would have predicted. So that to me was somewhat reassuring that these new drugs don't seem to be causing people to go into AFib. But that's something that we're going to need to keep in mind as we continue with myosin inhibitors, as we study new drugs and think about approving new drugs. If there's a signal that some of these newer drugs could cause AFib, that would give me pause, because you treat the obstruction, make people feel better, but then you knock them into AFib and they start feeling worse again. And so that's a good question. I would say so far the myosin inhibitors have shown positive remodeling and that the atria are looking healthier after getting rid of all the pressure.
Thank you very much. And Gwen, thanks for your comments. We have an interesting question. And sometimes when you ask questions, I'm going to break them down because terminology does matter. Does having, I believe you mean a pacemaker with HOCM, so obstruction in your HCM, reduce your chance of a stroke or heart attack? We're going to break that apart. And Camzyos is working well, but septum not narrowing. So I'm going to break this into a couple pieces for Alex to go through with me. Number one, pacemaker utilization in hypertrophic cardiomyopathy is not the common path. We typically are going to put in a defibrillator. Some might have backup pacing potential, but how often are we actually pacing people who have hypertrophic cardiomyopathy with obstruction?
Very rarely, and at least in my practice. And I would say that, so the idea came from data from a while back that if you think about the left ventricle and how it squeezes, and you think about this part, my right hand being the thick muscle that's obstructing blood flow, and my left hand being the other side of the left ventricle. When the left ventricle squeezes like this, that thick muscle is obstructing flow. And what they used to try was they would take a pacemaker, and instead of having the heart contract like it normally does, they would pace the heart. So beat for it electrically. And that pacing is not a natural way for the heart to move. It usually makes it less synchronous. And so it makes one wall move at a different time than the other. So instead of like this, when you pace, it kind of moves like this. And that dysynchrony, the idea being that if we make the septum not move as naturally, that maybe just making it move slightly off will help relieve obstruction. And there has been times, and I've done it myself, where you can pace somebody and it can increase their obstruction or decrease their obstruction some. And some people did find some clinical benefit from it. I would say in our thousands of patients, I can think of like 4, maybe.
I was patient number 103 in the dual chamber pacing protocol at the NIH in the early 90s.
Yeah.
So I spent 6 years dual chamber paced.
Yeah.
And it did not help me in the long run. It might have given me a little extra energy in the short term, but it didn't do anything great for me.
Yeah.
And there's a bunch of people like me that were also in this trial, and they did not show that it was actually effective for the majority. There was a big placebo effect.
Yeah. And so I've gotten to the point where I've had patients that have been referred to me with a pacemaker that's we call that forced RV pacing, where you don't really need the pacemaker, but we are pacing you just to try and get rid of the obstruction. And one patient in particular sticks on my mind was forced RV paced and on disopyramide. I weaned off the disopyramide. I stopped pacing them as I was starting mavacamten. Like I did it all together. And he feels like a totally different person. And the interesting thing was they couldn't really find obstruction when he was pacing and all this stuff, but I think it was there and we just weren't detecting it. And so long story short, I don't pace very often. I don't think it's a benefit.
If the device is already there and you got the tools to play with and you see if it works, but there could be some other consequences. So a pacemaker doesn't change your risk of stroke. You would need an anticoagulant to help reduce chance of stroke. And then the term heart attack. There's a difference between a sudden cardiac arrest, which is why we put in ICDs, and a heart attack, which is the occlusion of a vessel inside the heart wall, causing lack of blood flow to a piece of your heart, thus killing it and leaving necrotic tissue in its wake. We don't do that in HCM. We have cardiac arrest, which is a rhythm disturbance. We don't have heart attacks. Dr. Alex, how did I do with that explanation?
I think it's great. It's challenging, especially when you're taking a family history for your remote family members, like 2 generations back. Everyone died of a heart attack back many years ago because they didn't do autopsies and it was just presumed.
Yeah.
So you do have to keep that in mind that family members that died at 35 of a heart attack might have not been truly a heart attack. It might have been, like Lisa was saying, an abnormal heart rhythm due to HCM, potentially. But yes, she described heart attack perfectly, and a stroke is just a heart attack of the brain. And so
that is a good way of putting it. I am going to be getting off to an airplane in a few minutes, but one of my other favorite people just showed up in the chat. So we're going to bring it on screen here. And it's a big comment, and he's an important person to me. So Alex, I'm going to take a sidebar moment here. In the summer of 1995, when my sister lay in a coma, having had a cardiac arrest 2 days earlier, I was in my obstetrician's office trying to figure out if my baby was okay because I was 8 months pregnant when my sister was in CCU dying. And I came across People magazine. And on the back page of People magazine, there was a story of the gentleman named Robert Pensack, who is the author of a book called Raising Lazarus. It's on my bookshelf. And Bob's story was of his heart transplant and having received his heart transplant after a long-standing diagnosis of idiopathic hypertrophic subaortic stenosis, or HCM. I may have defiled the magazine in my doctor's office and ripped out the page and took it home. And he was one of the very first people I reached out to when I started to form the HCMA in the wake of my sister's death. So Bob, good to see you here. Thank you for joining us. You should come on here. We should talk sometime. He's a really wonderful human being and a great physician as well. He was a psychiatrist, and he's survived 34 years with his heart transplant, which makes him one of my all-time heroes, up there with Claude Brady, living 3 decades past transplants. An amazing thought. I haven't even finished one yet. So Bob, I aspire to be like you someday. So thank you for sharing your comments with us. And your medical professionals with big hearts. And it's a small group.
I'd love to meet him someday.
You would definitely. Bob, come out to the meeting in October. Come on, let's get you out here. I'm building a mental health network. I need you. Oh, one more question. Thank you for bringing that up, Demi. Kathy wants to know what MABA, and I'm going to include myosin inhibitors as a class. So that would include AFI and MABA. What do they do to healthy heart tissue?
Well, one of the initial questions is the idea behind mavacamten is taking heart tissue that's squeezing too hard and making it squeeze a little bit more normally. One of my initial things I wanted to make sure is heart muscle that's squeezing normally going to become weak? So I looked at that a lot. I read all the mavacamten echoes at Penn, so I probably read, I don't know. We have 250 something patients on mavacamten, and many of them have had 6 echoes a year. So I've read thousands of them. And what I've seen so far is that, for instance, the right side of the heart, the right ventricle that tends to be healthy, also continues to look healthy. The other walls of the left ventricle also continue to look fine. In a subset of patients that we've repeated the MRIs in them years after they've been on mavacamten, there are a couple that the thick muscle looks slightly less thick than it was before, but that is not all patients, and that is honestly not the expectation. So don't go into a medicine like this and expect that your heart thickness is going to go back to normal or decrease significantly. The goal is to get rid of the obstruction and the symptoms, and maybe there's going to be some positive remodeling with how thick the muscle is, but it shouldn't be an expectation. So overall, we haven't seen anything negative happen to the healthier heart tissue yet. Some people get too much dose of the drug and their overall heart function goes down, and then we have to stop the drug and then reassess dosing and things like that. But for the most part, it's been a pretty safe drug.
Very good to hear. And looking at the data from the earliest days of looking under a microscope and seeing how some cardiac cells respond to myosin, just the manner in which they normalize made me feel a little bit more comfortable about how the other parts of the heart would react where there isn't so much involvement. So the early science looked like it was going to be sparing any normal heart muscle from involvement or negative involvement. And I think we've proven that over time. But I'm going off to ACC right now to go get some late breaking data and see what else we can learn about this stuff. So stay tuned over the weekend. Alex, as always, thank you for joining me on Tales from the Heart. And for all of you who are still out there or just joining us, please do take a moment to take our about 10-minute survey on life with genetic heart muscle disorders and share with us your wishes to talk to the FDA about what you want for future therapies, for future trials, and for future opportunities to try. Thank you so much for joining us today. And I got an airplane to catch, I hope. Thanks, Alex.
Yep, of course.
Tales from the Heart wants to thank our sponsors, Bristol Myers Squibb, Cytokinetics, Edgewise Therapeutics, Lexicon Pharmaceuticals, Alnylam Pharmaceuticals, Rocket Pharmaceuticals, Imbria Pharmaceuticals, and Tenaya Therapeutics.